I think the ongoing trials looking at agents that are not yet FDA approved, as well as the currently FDA approved trials, you're going to focus on clearly those individuals that are more likely to respond to a certain therapy. So I think biomarkers are really going to be very, very important to help identify those patients. In all honesty, I think combination therapies are going to become increasingly important. We kind of emphasize the fact that we think that many patients, perhaps the majority, will in fact see many of these medications or many of these therapies that are placed into the bladder. And the question is obviously sequencing, who's going to respond. But I think many times we may even consider in the future combination of these therapies. So where will the research go? I think it'll be in biomarkers. I think that it will be difficult and expensive to do formal large studies regarding sequencing. So I wouldn't be surprised if we have registry type data or real world type data looking at the response, very similar to other therapies that we've had in advanced prostate cancer and advanced kidney cancer in terms of where we go with the different options that we have. We'll get that data. That may not be level one data, but will be important. But I think we'll definitely be able to utilize some of the urinary markers or tissue markers that'll help identify who's going to be more likely to respond to different therapies. That'll be very important as we prioritize which therapy may be first. And then secondly, I think combination therapies will be looked at not only in this clinical situation, but earlier in the disease process.
Do you think we're close to the point where the single arm trial is no longer acceptable and that there is a standard of care to compare to?
If I were the FDA, I would say that in the BCG unresponsive space, you're going to need a comparator arm at this point. What that comparator arm would be, could be, should be, it's a more difficult question, but I could see it as a comparator arm of being another intravesical therapy. And do you define that as an FDA approved agency or rather agent? Do you allow actually a combination chemotherapy, the gemcitabine and docetaxel, which where we have retrospective data, it's become a default accepted therapy regimen. Do we use that? That I need to think about more, but I think, in the future, beyond the trials that are currently accruing, you're going to have, I think, a comparator arm in terms of achieving approval. There are some exciting trials that are currently accruing patients, though, Dan. If you look at different immunotherapeutic type options, if you look at obviously chemotherapy options, obviously the TAR-200 with a delivery system that's different. Memorial's doing actually an ongoing trial looking at an alternating regimen of BCG with chemotherapy in an attempt to augment the immune response. And so we've got exciting new agents, new chemotherapy regimens, new immunotherapy regimens, new delivery systems with chemotherapy agents. I think it's an exciting time. And importantly, each of these studies in some way are going to be looked at earlier disease states.